Welcome to Save Your Breasts, the podcast where we empower and educate women in making an informed decision about their breast cancer treatment and reconstruction options. Today, joining us is Dr. Sadia Khan, a breast surgical oncologist, the medical director for breast oncology, surgical oncology, and a co-director with Dr. Savalia for the Oncoplastic Fellowship over at Hoag Hospital. Welcome, Dr. Khan.
Thanks for having me.
Yeah. Dr. Khan, before we dive in, why don't you tell us a little bit about yourself and how you ended up where you are today as a breast surgical oncologist?
Sure. I'm very passionate about breast surgery. I developed the interest when I was in residency and training. Breast surgery was unique because you get to know the patients really well and kind of follow them throughout their journey over the years. And I loved that part of connecting with patients. So I am currently the medical director over at Hoag, and Dr. Savalia and I are very passionate about oncoplastic breast surgery, and we developed the first fellowship that's advanced and specific for oncoplastics here in the United States.
Thank you. And Dr. Khan, or Dr. Savalia, you've worked with Dr. Khan for a number of years.
Oh, yeah.
Tell us about your collaboration with Dr. Khan and what stands out to you about her approach with your patients.
Well, I think we should start by first noting that Dr. Khan did her fellowship as at least part of the fellowship at Hoag Hospital.
Mm-hmm.
She did the breast surgery training at USC, but she rotated through Hoag Hospital for about, was it 6 months?
Yeah, about
6 months, which is probably the longest most people do because usually it's 4 months of rotation, but we got to have her for 6 months at Hoag, during which time I was involved in her training along with Dr. Melvin Silverstein. And she was a standout at that point, right there. Right then and there, it was clear that she was heads and shoulders above many of her peers as, barely a breast surgeon at that point. So just by that experience alone, within a couple of months, I knew that if Hoag had a chance to keep her, that they should keep her. And of course, it manifested. Here she is. And 10 years later, I think, she's now the actual director of the breast program. She's really carved a whole career out of this for herself. That's quite phenomenal. And I think the things that now stand out to me about her are just amplifications of what she displayed in her training, which is her tenacity. It's the tenacity with which she approaches patient care. She doesn't ever give up on a particular problem. If there's some little nuance of something that needs to be done, she makes sure every little detail is attended to, because she truly, truly wants to deliver the best care she can. And that is obvious on a day-to-day basis. She truly goes to war for her patients. That's what I see.
Your guys' patients feel that too. They know that they're in really good hands with both of you. So let's start with early detection. Everybody knows, or we know, that breast cancer caught early, or any breast disease caught early, gives more options for the patient surgical wise. So what are the most important things about screening for each of your patient? What do you tell them?
So there's some confusion, I think, in the general public about when to start your mammograms, but mammograms definitely are the main reason that we are where we are today, where breast cancer is overall very, very curable, and the majority of patients do really well. So screening mammograms should start at minimum at age 40. I know there's some confusing messaging about 50 and 40, and we kind of went back and forth, but with so much young breast cancer now, we've really gone back to that. Starting at 40 would be the minimum. And even some patients, after you talk to your doctor, if you have a lot of family history or there's other risk factors, you might even need to start earlier than that. So maybe like a baseline mammogram around 35. And if everything's okay, wait till 40, just depending on your risk factors. So it's super important for women to at least start the screening and do it early. I've heard kind of from patients, like, what if I do it every 2 years? And the reality is, if we can catch your cancer early before it spreads to a lymph node, before you need chemo, before it becomes advanced, you're going to have a better overall outcome.
So what do you tell women who've been told by their other doctors, well-intentioned doctors, that there was a new guideline, I think it was how many years ago, 5 years ago, that was introduced to say that maybe we don't have to start screening until you're 50?
Yeah. I mean, part of the issue is obviously healthcare costs go into a lot of these decisions. Unfortunately, that particular guideline that had changed to mammograms to 50 and doing it every 2 years that's where the confusion comes from. That guideline was based on no physicians were involved that take care of breast cancer patients in that particular task force, which is a little bit problematic, but ultimately what it comes down to is the earlier we detect your cancer, the less likely you are to need advanced treatments. And I think every woman can relate to that. When I do give the diagnoses, it's great to say, hey, we caught it early. We're going to beat this. You're going to get through this versus, hey, your cancer's quite advanced. You're going to need chemo. You're going to, so we would love to be able to tell patients that first one where it's like, hey, this is going to be easy. It's going to be a simple surgery. You're going to get through this and move on from it. So ultimately, detecting early means smaller cancers and less advanced.
What self-exams do you tell patients to perform at home so that they can help catch early enough so that they have those options without advanced treatments?
Yeah. And so the majority of breast cancer probably isn't going to be necessarily a lump or something that you feel. But if you know your breasts the best and then you detect a change, you'd be the first person who could alert your doctor, like, hey, something's wrong. This feels funny. Other things that patients should be looking for, not just lumps, is like nipple changes. So if your nipple inverts all of a sudden, if you had nipple discharge that was bloody, or even just kind of a little bit of fluid on the back of your bra, things like that, any dimpling in the skin that's unexplained, or a rash that doesn't go away, those would all be things that might alert you to let your doctor know so we can do some workup and make sure there isn't anything worrisome there.
And what key risk factors should women be aware of?
So some of the breast cancer, there's a lot of reasons. So we don't really know why some women develop breast cancer, but the 5 objective risk factors that women can affect as far as their risk is losing weight. Obesity is definitely a risk factor for breast cancer. Exercising 150 minutes of moderate to brisk cardiovascular exercise helps immensely. That one particular risk factor can reduce risk by like 15 to 18%. Making sure you're eating like a colorful diet that has, various vitamins and antioxidants, any of those foods that are superfoods. Darker green leafy veggies have a particular enzyme that can be risk reductive for breast cancer. Kind of a little tangent of that is a lot of women take turmeric because of the anti-inflammatory properties. So that would be another way. Also, no smoking and limiting all alcohol intake, because that is a risk factor for breast cancer. So those are things that you can control. Outside of that, there's obviously other factors like how we handle stress and our, family history, genetics, things like that you don't control.
Okay.
So do what my mom said. Eat healthy and don't drink.
Yeah, did you follow those guidelines?
I mean, people can do all of those things and you may still, breast cancer is so common, 1 in 8 women, that you can only do what you can, and then just do the screening and early detection and making sure you're letting your doctor know if anything changes.
Yeah, just don't be naive to the fact that
it could happen. Yeah, I definitely hear from patients like, oh, I don't have a family history, so I'm not going to develop breast cancer. But interestingly, 85% of women with breast cancer never had a family history. So definitely it should be in the back of everybody's mind, just being healthy and making sure that you're keeping up with the screening.
Yep.
Don't forget the screening.
Yeah, the screening is so
even
important.
if you do everything right.
Yeah.
Right. Yeah, there's still a risk.
Yeah, absolutely. Let's move on to advancements in breast surgery for breast disease. Even in your time of practicing medicine, you've seen changes, right? And some of that you've been a part of, I'm sure. But what advancements have you seen, and what are you seeing for future in this?
Probably from a surgical perspective, the best part of my training with Dr. Savalia and Dr. Silverstein obviously was learning the oncoplastic approach to looking at breast cancer patients and disease. So standard breast surgery involves either lumpectomy or mastectomy to remove cancers. And then I had the fortunate ability to be trained in oncoplastics and my patients one additional option. So oncoplastic surgery really melds like plastic surgery techniques and using those principles to use on breast cancer patients so that they're not just their oncologic or cancer outcomes are good, but they're actually really happy with the aesthetic and overall cosmetic outcomes of their breast surgery as well. So there's been a huge push probably in the last few years nationally, making oncoplastic surgery much more popular and more mainstream. And, I've seen that change kind of happen when I was applying for fellowship and going around all across the US interviewing. Oncoplastic surgery was not really popular. It was, not to say it wasn't around in Europe and other places, but it wasn't common or practiced here in the United States, except for at this particular program, USC Hoag, which is definitely the reason, it was like my top choice. And I was so lucky that I got to train there and train with Dr. Savalia, who is nationally recognized and has trained many surgeons in his career. And I get to benefit from him taking care of my patient. It's kind of like the best of both worlds. So
Absolutely.
Go ahead.
Sorry, I was going to say, just to say, the term oncoplasty, when we would talk about it 15 years ago, we'd have to give a definition of it to any doctor we were talking to, of what it was. And now everyone kind of knows what it is. So that's how far it's come in 15 years. Is that the term oncoplastic surgery now has become truly understood and kind of mainstream amongst the breast surgery world. Whereas before it was this vague idea of something that they didn't really know what it was. You have to explain it to every single person.
One small little paragraph in school for you, and look what it is now.
That's right. You remember my story.
I remember your story. And how have these advancements, Dr. Savalia, changed your practice?
It defined my practice, honestly. It didn't change my practice. I was very young in my practice when I happened to get the opportunity to really, really work with a established breast surgeon who understood oncoplastic surgery and needed a plastic surgeon to do these cases with. So I was only 3 years into my practice. I was basically a baby. I had no idea what's going on. So it has essentially defined my practice for the last 15 or so years, 17 years now, actually. So, and you're part of the practice, and you see what kind of volume of work we've done over the past 15 years, right?
Oh, yeah.
Talking, I think at last count was over 1,500 women that we've done oncoplastic procedures on, not just mastectomies. I'm excluding those. I'm talking just oncoplastic surgery. So that's 1,500 women that we've been able to spare from having to have a mastectomy.
Yeah.
Honestly.
Yeah.
I mean, honestly, that, when I'm seeing patients, I think there's 2 points that are like the biggest fear from the patient perspective is, am I going to need chemo? And do I need a mastectomy? And, being able to give women an option, of course, there's always going to be times that women may be recommended or need a mastectomy, but the majority of women want to preserve their breasts if it's oncologically safe, right? The goal, whether it's a lumpectomy or a mastectomy, is always cancer-free at the end of the surgery. So if we can give them that option, having this additional tool where we can take out large volumes of tissue and I can get wide margins, but have Dr. Savalia there to make them look beautiful at the end is, it's like icing on the cake, being able to be cancer-free and happy with your aesthetic outcomes.
Yeah. And with those treatment options, even though you guide them with their options and you kind of tell them you're going to be okay if you choose a lumpectomy, some patients still choose a mastectomy. Why do you think that is?
I mean, ultimately, we want the patient to be involved in the entire decision process. I try to treat patients the way that I would want to be treated, or if they're my family, like how would I counsel them? So they have to know all of their options. And then obviously there might be a suggestion like, hey, I think you'd be a great candidate for X, Y, and Z. And it's really tailoring my conversations and approach to, not just what their cancer is or the size and the shape, there's a lot more of like trying to understand who they are as a person, what affects them, how their family life is, trying to get to know them personally so that it's a more personalized discussion. So each patient's going to be very different. Genetics may play a role into decision making for mastectomy, like a BRCA1 gene mutation carrier is at a higher risk for developing future breast cancer. So that patient may not want to do breast saving surgery, and that's okay. So, each patient's going to help make that individual decision. I'm just there to help them understand all of their options. And, if they can have this wonderful combination of oncoplastic surgery, great. It's a wonderful tool for a lot of women, and it gives them, a little bit more reassurance than just a standard lumpectomy, because we're taking out a smaller volume of tissue and putting them back together.
Right.
When I have the benefit of having Dr. Savalia there, I tell women, 30 to 40% of your breasts have to be gone to do this reduction and lift combination.
Mm-hmm.
So whatever their current risk is, you're eliminating a large volume of tissue that can never develop breast cancer again. So we are reducing their risk in theory when they are having this surgery. So it's kind of like a nice in between of giving them options.
Yeah, we get that question a lot actually with breast reductions and reducing my risk with breast cancer by doing a breast reduction. So it's good to hear that from you, because we always tell them that. Dr. Khan.
Well, I think a lot of women, going back to your original question, it's a knee jerk to want to choose a mastectomy.
Yeah.
Right. And it's okay to choose a mastectomy, but I don't think it's okay to do it without being well informed of what all your options are and what the ramifications, the pros and cons are.
Yeah, definitely.
So after hearing a conversation with Dr. Khan, I think if they choose a mastectomy, then that's an appropriate decision for them.
Right.
Yeah. Well, there's a lot of women that come in, and there's quite a bit of misconceptions, I think, around mastectomy. So we always hear like, I want a mastectomy. I want a double mastectomy. I don't need them. I just want to live. And that small kind of term, honestly, the surgical decision that women make, whether it's lumpectomy, mastectomy, it doesn't change how long they live, because the biology of our cancer is what will decide how advanced the cancers are. There's this, I know a lot of women focus on breast cancer that developed in the breast that showed up on a mammogram, where they felt a lump. But all women with invasive breast cancer, which is true breast cancer, some small segments of that cancer, little tiny stem cells from that cancer, live in the bloodstream for the rest of that person's life. And that's true for all cancers. It's not just specific for breast. If you had colon cancer, lung cancer, so there's always this fear of reoccurrence, which can mean two different things. There's local reoccurrence in the breast from having the tumor sitting there and then removing it and having potential cells left there, which is mitigated by radiation. So that helps with that. But regardless of what you do surgically, those cells that are living in the bloodstream are not affected by your choice of mastectomy and lumpectomy. So that is, a really important concept to understand for patients, that your surgical decision doesn't affect whether your cancer is going to spread to the liver, the lung, the bone, or never spread, right? That is the goal, is that systemic treatment like chemo or anti-estrogen therapy. People, have heard the word tamoxifen thrown around. So those are the therapies that affect those cells and coat them so they never turn into a new cancer. But your surgical decision doesn't decide that. So the good news is that whether you have more advanced surgery, more aggressive surgery, it's not going to affect all of those really important outcomes, like how long you're going to live. So it leaves women with more choices.
Yeah. And a lot of women, we've talked about this before, they'll meet with you or their other breast surgeon of their choice, and then they'll come in and they're still undecided. They don't make a decision until they meet with him and he lays out the reconstruction options. Yeah. And that kind of solidifies their decisions.
Yeah, I do think also women, like I often hear from women like, isn't a one and done surgery, like I can have a mastectomy and I'm done, and they don't realize that there's a lot more to that particular surgical reconstructive option. So I usually try to like give them, like, hey, it's at least 2 to 3 surgeries. We're not doing the final reconstruction of that first part.
Right.
And so that's definitely something that gives patients some pause. And then also the concept of like losing sensation to their breasts. Not every I know Dr. Savalia and I have done a lot of combo cases where we have given women the option for nerve reconstruction so they can maintain that nipple sensation. But you have to have a particular body type and a very specific size breast. So not everybody is a candidate for that, which it would be great if we could offer that to all women who end up with mastectomy. But it's also common for me to hear that women don't realize that a mastectomy means losing all sensation,
Right.
touch, feel, sexual touch to the breast.
Right. And that plays a big part in some women's lives. Doesn't matter to some people, but others.
Of course. No, I think it's a huge part of all women's lives, and just, that overall change of like who you are, how you feel, things that make you feel like a woman. I think that's, it's really important for the breast surgeons to go over that in detail when women are considering their surgical options.
Absolutely. Absolutely. And Dr. Savalia, when do you get involved in this decision-making process?
Well, from the beginning, obviously, before any decision has been made, I rely on the breast surgeons to have counseled the patients regarding, obviously, what their ideal cancer treatment is. Once that's been established, then I have a clear path forward to say, well, with this in mind of what your cancer treatment is, these are your reconstructive options, right? And when I meet with most patients, sometimes they have a clear idea that they definitely don't want a mastectomy, and they'll do anything to avoid a mastectomy.
Right.
And those patients, maybe the conversation is a little bit more straightforward if oncoplastic surgery is an option. Patients who come to me not quite sure about mastectomy or double mastectomy, that's a longer conversation because I do have to go quite in depth into what the actual steps are for the reconstruction, what the ramifications are. That, as you alluded to, they have to know that they're going to have numbness everywhere on the chest, the nipple. And
some of them don't even get to keep their nipple, right?
Right, if they get to keep it. And what their options for reconstruction are, whether it's implants or whether it's their own tissue, what the pros and cons of each are, what the maintenance of each one is over a lifetime, that sort of thing. So those conversations play a role, as well as discussing what radiation does on top of all of those things.
Yeah.
So it's this whole convoluted discussion that I try to put a light on so that they can see that this path leads to this, and this path leads to this, and this path leads to this, so that we can make a decision together.
Yep.
Can I just say, like, honestly, having a plastic surgeon who even understands to that depth the type of breast cancer, Dr. Savalia is so committed to our breast cancer patients. That's honestly one of the reasons my patients are so happy when they're seeing him. He's attended all of our breast cancer tumor boards for years. So he has this in-depth knowledge of my part of the surgery, like the cancer part, even the aftercare, the radiation, the chemotherapy, and how that plays a role in what he's helping these patients achieve. So it's so important for women to understand having not just a breast cancer surgeon who understands those perspectives, but my reconstructive surgeon also understands what radiation is going to do to my breast, how it's going to affect my reconstruction, and can speak to that.
Right.
Not after it's happened when you're unhappy with whatever's happened. They can help prepare you for what to expect and can understand the nuances and help you make the right decision that makes sense for you. So we're so fortunate to have somebody that really understands that.
Yeah. I think we can say vice versa too, right?
The
breast surgeon understanding the plastic surgeon side helps you too.
Right. No, I was going to say that, we see patients from outside of our system, from the community, from other counties, that maybe were diagnosed with breast cancer, and they were told to go see a breast surgeon. Not told who to go see or made appointments, had appointments. They were just told to kind of go find one. And then the breast surgeon sees them and gives them maybe one or two options and say, well, you need a plastic surgeon. Okay, well, who do I go to? They kind of have to find their own plastic surgeon. And then all this care is just kind of disjointed. There's nobody really navigating the whole process for them and coordinating it all.
Right.
So for us at our system, it's a very well-oiled machine. Not that we want a machine that can handle all this, but we would love to never have to deal with it. But since we do, we want to be able to take patients from point A to point B to point C and help guide them through the whole process. And not just guide them through the whole process, but put them with people that understand each other's roles, right? And like you said, I have to know what you're doing. You have to know what I'm doing. We have to know what the radiation doctors are going to do. We have to know what the medical oncology doctors are going to do it. Like, we have to know these people intimately that we're working with. You can't just send our patients to some random radiation doctor or some random breast surgeon or plastic surgeon that will coordinate a team together. No, this has to be a team that's worked together for years and knows each other and understands the nuances of every little aspect of what they do and how it's going to impact and how it impacts the rest of their care with the rest of the team.
Right.
Yeah, I mean, at Hope, we are one of the highest volume breast cancer surgeries in the state of California because we just get so much volume. And I think that speaks to our experience. And hopefully, we've kind of packaged it up so it's, we never want women to be diagnosed with breast cancer, but if they are diagnosed with breast cancer, we are here to help kind of guide them through that journey and make sure at each of the points that they're seeing kind of the best doctors and getting the best care.
Right. And the system that Hoag has in place really alleviates a lot of stress to the patient.
Yeah.
You're diagnosed and your mind just starts spiraling and you don't know who to go and who to see and who to
like
talk
who's
to.
going to call around and make appointments and make sure you accept my insurance, all of those things.
Exactly. So our patients are, they're very lucky to be in the hands and be able to be guided because we have seen outside, patients who...
Oh, it's terrible.
I feel so bad for them because they have no idea. They weren't told X, Y, and Z. They didn't know this was going to be their path. And it's just, I would hate to go into something and not know what I was looking at for my journey. And Hoag does a really good job. You guys do a really good job of paving that path. So patients ask me all the time what they can expect day of surgery, if you guys will even be in the OR together, which I find funny because I know you guys are like attached at the hip in the OR. And I always joke with them and say they know each other so well they could probably do each other's portion of the surgery at this point, because you guys have been doing this together for so long. You were a fellow and watched his portion solely, and now you guys are co-directors of the fellowship. So tell me how you guys explain to your patients your team, basically.
So typically, I mean, usually I'm meeting the patients and, I do actually get that question a lot. So I think in many hospitals that I'm aware of, the breast surgeons kind of work in silo and they do their breast cancer part and no plastic surgeons in sight. They've communicated, obviously before surgery. And then the plastic surgeon comes in and the breast surgeon's gone off to do the next surgery. We don't function like that. We are definitely a team. We want the patient to benefit from both of us being there at the same time. So there can be real-time discussions on margins and, aesthetic outcomes. And hey, if I take this piece, how's that going to affect what you do from a reconstructive standpoint? So we are there at all times. And, that's a huge commitment for Dr. Savalia to be able to, block out hours of his day waiting for me to do the cancer portion, but so that he can be there at the same time. So I think that team effort, is unique for us, and many hospitals don't offer that. So that's number one. But what patients can expect is Dr. Savalia and I will be there the entire time together, meaning in pre-op, when you're getting marked by Dr. Savalia, I'm there, discussing with him like, hey, this is my portion of the case. This is how much tissue I think I'm going to be taking. He's marking them. I'm there. We're communicating about the plan, even though obviously we've discussed and we have a whole plan ready to go, seeing what the area of resection looks like the day of surgery when, preoperative lokes have done, wires have been placed, it changes slightly. So we're always kind of working together to make sure that our patient's plan makes sense.
Right.
And then I'll do my part of the cancer case. And usually if we're doing, like, for example, oncoplastic surgery, Dr. Savalia is working on the other breast. So we're not just having the patient under anesthesia for hours and hours and hours unnecessarily. So I'll be doing the cancer side while he's working on the opposite breast. And then when I'm done, he'll come and finish the reconstruction. And it saves the patient quite a bit of time. So we're typically doing these cases in 2.5 hours to 3 hours of general anesthesia. Patients do really well. We do a lighter anesthesia over at Hoag. So they're awake at the end of the case. They go to recovery usually for about an hour or so. And the best part is patients recover really well. It's outpatient surgery. They're going home the same day. We typically never leave drains. Almost nobody, of course, there's always complications. So if you had an infection, you need antibiotics, but patients honestly are really fortunate and they do amazing. And, they have Dr. Savalia there to make it look great. And, hopefully I've done an awesome cancer surgery so they're cancer free too.
Yeah, most of my patients are calling me like a week later saying, I really have to wait 4 weeks to go back to my regular life.
Yeah. I mean, I do tell patients, I'm like, you're going to feel like you didn't have a major surgery,
so
but you
true.
had a true major surgery. So
Mhm.
you have to take it easy,
Yeah.
take a break. I mean,
Yeah, you went through something serious.
yeah,
Like,
definitely.
take advantage of this.
I do think patients are surprised,
Totally.
in cancer, breast surgery is a little bit different because it's like on the outside of your body. You're up and walking right away. You kind of feel normal. You can eat,
Mhm.
Yeah, I think it can be misleading, but definitely it's awesome to offer women this outpatient option that's usually better than they expect.
It's kind of an anticlimactic recovery,
Yeah.
right? Because they've gone through this whole emotional
Yeah.
turmoil leading up to it, and they're kind of going into the day of surgery, just like sometimes, emotionally,
Overwhelmed.
not, I don't want to say wrecks, but still emotional on the day,
Overwhelmed, yeah.
overwhelmed, not sure what's gonna happen. Then they wake up from surgery and they're home like, oh, I forgot to take my Tylenol. Like, I don't even have any pain.
Yeah.
Minimal, right? Like, so.
Yeah.
And then they look and they're like, well, my breasts look great. I thought I was supposed to be a mess right now.
Yeah.
And so there's a little bit of an anticlimactic moment of, I thought it was gonna be the big deal, and it turned out to be
a little bit easier than we thought.
Yeah.
I mean, Dr. Savalia has also led up the ERAS protocol over at Hoag. So he's helped develop a pain protocol to help women, go through this journey and feel comfortable, have it be the easiest, we're not doing the antiquated after midnight, don't eat or drink anything, we're not torturing patients anymore.
Yeah.
So, he's really led up that entire program. So we have patients that are comfortable, pain-free. They've got their pain medicine up front. Most patients don't end up ever really even needing narcotics. We do a lot of pain control intraoperatively to help prevent that from happening. So that's been amazing for our program.
It really has. I've seen even mastectomy patients who have very little
plain
pain.
Tylenol.
It's really wild.
I swear patients never believe it up front.
They never
and I always
believe it.
tell them, I'm like, here are the numbers. If you have any issues, we're happy to take care of you at any time of the night and more, whatever. Just call us. But I swear it's going to be easier than you think.
I think that's the most that I talk about in my pre-op appointments is promise this Tylenol
it's not going to be bad.
Are you sure just Tylenol and Advil?
Yeah, exactly.
Yeah.
Sugar? What? I have to drink
sugar
I
tell patients, I'm like, I will give you something. Don't worry. You'll have a prescription just in case. But 99.9% of patients never even fill it.
Yeah. It's hard for them to wrap their heads around.
Yeah,
for sure. So for women who unfortunately do have a diagnosis of breast disease, and they aren't fortunate enough to have Hoag nearby or even as an option because of insurance, what would you suggest them asking and helping them make their decision?
Yeah, I mean, the first thing, obviously, we've talked a little bit about having like this core team of doctors who understands breast cancer. So if you aren't in, obviously in our area, there's lots of options. So a lot of patients do fly out here to get opinions from us. We're able to gather a lot of their information just through the telephone and maybe virtually look over their records and help make them, give them their options and decisions. We've had patients fly from, various parts of the country to come out and have, we've had Hawaii, people will definitely travel to have their breast cancer care with us. We have, again, we kind of talked a little bit about outpatient surgery. Patients do really well. Usually complications are going to happen in that first 48 hours or first few days. So patients will stay for a few days and fly back home, usually a couple days later. So it's totally manageable. But the main thing is just finding a breast cancer doctor that you can relate to and you can trust, right? You want somebody who's specifically trained to do breast surgery, who can give you all of your options. And if oncoplastic surgery isn't on the table because nobody discussed it, definitely kind of use your Google search and look for somebody who does oncoplastic surgery, has, been trained in oncoplastic surgery so that you are getting the full breadth of options, not just lumpectomy, mastectomy.
So if somebody's out of state, let's say, right, and wants to come to Hoag, or they've heard about Hoag, and they feel like maybe they're willing to travel. How do they coordinate that?
Yeah, so we actually have so I have a nurse navigator that patients can reach out to the breast center and they can get a hold of her and she'll do all the coordinating for them. So she helps to get their records, she helps to get all of their imaging to our breast radiologist. They'll request the pathology slide. So we do a full review of their cancer care thus far, and then pretty usually once I've looked at the imaging and kind of looked over pathology, I have a good idea of kind of at least the cancer perspective, and then we can talk to the patient, have them fly out for an appointment, get an idea of size and shape of their breasts and how those two things work together to see if they're a candidate for oncoplastic surgery or standard lumpectomy, mastectomy.
Yeah, I think the idea is that you can gather all the information virtually
Yeah.
ahead of time, make some preliminary evaluations.
Have some good ideas of like what we can
Right.
offer them.
Because you do have a certain amount of time. Once you get your diagnosis, it's not like you have to be in the operating room that next week. You
Yeah.
have time to
But remember,
research.
when patients get the diagnosis, they want to be in the
Of
operating
course.
room
Yes.
yesterday.
Yes,
Of
they
course.
do.
Yeah,
That
and
is
we
without a doubt.
realize that, but
Right.
that's true. It takes 5 to 10 years for one bad mutated cancer cell to get big enough to even detect on imaging, or for somebody to feel as a lump.
Wow.
Yeah.
So that process is a time period over years, but once we know it's there is kind of like a clicking, like a clock that's.
There's a clock, but the
Clock
clock
that's
is not as
ticking.
fast as they think.
Yeah.
And they have time to think about some of their options. They have time
And
to
make an
even
educated
come out here.
decision, right?
You're right.
The goal is not to rush to surgery and not even understand what all of your options were out of fear. So that's the key thing, is there is a time frame. Less than 45 days would be the best goal, but technically you have up to 3 months from the day you were diagnosed. But we want to stay in that 45-day window where totally safe, no reason to believe anything's changing in your cancer care. But we want to make sure our patients have had time to do genetic testing if they wanted it, have had an opportunity to meet with, the reconstructive surgeon and understand all the nuances of that part of the reconstruction, and, have all the options available to them.
I want to drive home the point.
Okay.
If you have cancer and you don't live near us, you can send us your information. It can be reviewed. We can have a decision of whether it's worth for you to fly out here
Definitely.
and come here for care, so that you don't have to necessarily stay in your region with doctors maybe that you don't have access to, or maybe don't feel like you have access to good doctors that you want. So you can come out here, fly out here, we can take care of you, you can have your surgery and be on a plane back home that
In a
following
few days,
week.
yeah.
Yeah. You can do that.
Right.
And then you can potentially have the remainder of your care in your area and have follow-ups with medical oncologists in your area. That can happen. And we've done that.
Yeah.
Yeah, we have.
Definitely.
Speaking of traveling, there's a difference in European cancer treatment and cancer treatment here. What differences do you see there? Because I know a lot of patients have questions about that and why it's so different across seas.
I think, we talked a little bit about this change or evolution of breast surgery going from super aggressive oncologic treatment with no regard whatsoever of the aesthetic or cosmetic outcomes, and this shift in the United States where now more popularized this concept of like making sure that not just the cancer part of the care is really, really good, but also making sure that we're thinking about the way women look and feel and how their cosmetic and aesthetic outcomes of their breast surgery is going to be. In Europe, they're probably 25 years ahead of us, right? Where that revolution's already happened. So the breast surgeons in Europe are actually trained in oncoplastics. They already do their own tissue expanders, implants. So a breast surgeon, by definition, in Europe is going to be very different than a breast surgeon here. Here, we're really focused on breast oncology, the cancer perspectives. We're kind of like the team captain for the patient, getting them to all the different specialists and understanding the nuances of who needs chemo first, who needs chemo after, what type of radiation options do you have, what kind of reconstruction can you have. So it's a little bit different, but the combination of having a good breast surgeon plus your breast reconstruction options, it kind of lends you to the same model. It's just a little bit, it's one person versus two. Gotcha. So the partnership here.
Which actually speeds the process up, honestly, right? for one surgeon to do the lumpectomy, to do the lymph nodes, to do the reconstruction on that side, then go to the other breast
Yeah,
and fiddle with the other breast to make it symmetric. I mean, that's a long surgery
it
for one
is.
person to do.
Oh, yeah.
We can do that surgery in sometimes 2 hours or
2
less,
hours,
right?
exactly.
Yeah. And so in terms of efficiency of time spent in the operating
Yeah.
room, I think a two-team approach is far better.
Yeah. And I know you guys have nailed this together, but where do you see the future of oncoplastic breast surgery?
Well, the first step really is getting more surgeons trained to even offer this, right?
Yeah.
So there's a statistic through the American Society of Breast Surgeons, which is our major breast society, and about 80% of breast surgery is performed by general surgeons who are not specialty trained in breast. So part of it is just educating the majority of surgeons that are out there in the communities doing surgery to offer these techniques. They're not things that were taught in our residency programs. They currently still are not being taught in our residency programs. A majority of breast fellowships still don't teach oncoplastics. So for the first step is really just, physicians like Dr. Savalia and myself, we teach nationally at a lot of the conferences to offer these techniques. And to help make it more mainstream and offer it to women in all the various communities, not just our community. So that's the first step.
Okay.
And then our Advanced Oncoplastic Breast Fellowship was the first of its kind here in the United States, trying to mirror really what you talked about with Europe. Is we want the breast surgeons here to be trained to be able to offer these techniques to their patients. So both Dr. Savalia and I are co-director of the fellowship. It's a 1-year fellowship at Hoag. And we've had great interest in surgeons, either years in their practice or even fresh surgeons that are out of their breast fellowship that want that additional tool and training option. So I think that's the future of breast surgery, is getting more surgeons trained and being able to offer the full breadth of oncoplastics to their patients.
You have to be able to think oncoplastic.
Yes.
Yes, yeah, because oncoplastic surgery is kind of a mindset in the
Yeah.
beginning to understand that you don't have to choose a mastectomy just because
The size.
the size of it,
Yeah.
or there are all sorts of things that were just myths back in the day. So you have to train doctors to think differently about the problem first before they can actually create a solution. Because if they don't even see that there's a solution, they won't even think in that direction.
I know I'm interested to know how the fellowship actually looks like. What does it look like on your guys' end? What do you do?
Yeah,
How do these
so
patients find- or how
for
do these
years
patients-
both of us have been, and so I was a fellow at the USC Hoag Fellowship, and then for years, Dr. Savalia and I were also involved in training the standard breast oncology fellows. What's different about our fellowship is there's a focus on specifics like advanced oncoplastic techniques. Many of the breast fellows that rotated through standard breast fellowships are doing medical oncology, radiation oncology, genetics, they're doing this full continuum of breast cancer care. And the plastics or the reconstructive part is kind of like on the back burner. That's not the priority or
Right. They're still learning how to be breast surgeons first.
Correct.
Right.
So this is different because you're really every single day getting, one-on-one training with Dr. Savalia and our other plastic surgeons that do oncoplastics. And they're seeing that perspective from the clinical side from myself and the other breast surgeons that do oncoplastics, where you're learning those how do you think when you're meeting a patient? Like, what are all the options based on size and shape? And so it's very, it's amazing to offer this to patients. It's a 1-year training, and they're going to be super successful at offering these techniques to their patients when they're done.
That's awesome.
Yeah, it's a whole year where I also can participate and give them the kind of a focused concentration on what defines a breast in terms of beauty, aesthetics, what's an ideal breast, and then be able to take individual patients who maybe fall outside of those standard parameters that are in textbooks and say, well, how do you take this person's breast and look at it and define what you can do to even improve on it during a cancer treatment, right? Which is to say, how can you take a patient out of a situation where they have breast cancer, they're going to have a lumpectomy, they're going to have some sort of surgery that historically would have left them looking worse. Now they're going to come out of surgery looking better, right? So
or
it gives
at least
us a whole
more
year.
like themselves, right? That's the key thing. Women want, a lot of women want to go into surgery. It's like, I never wanted this to happen to me. I want to look exactly how I look now, or something in that similar. And I've said that, I've honestly done that to Dr. Savalia. So I'm like, she wants to look exactly the same.
Yes.
And amazingly, he's got ideas on how to make that work, right? But the majority of surgeons, even breast surgeons doing breast fellowships, never learn that in their training. So
Right. It's not even an option.
it's not even an option, yeah.
So we get a whole year with somebody to
To really
those
learn
points
in
home.
depth, yeah.
Yeah. It's the future. Okay, Dr. Khan, if you could leave this podcast with telling our viewers and our listeners one thing, what would you tell them?
The main thing is get a mammogram if you haven't had one. Make sure that you're kind of first just generally aware of what's happening in your breast, what's normal for you, so that if there was a change, you could let your doctor know. Detecting breast cancer early is key. And then the second thing is really understanding and making sure you are empowered and educated about all of your options. So whether lumpectomy, mastectomy, or oncoplastic surgery is something you're interested in, if you were ever in that situation and diagnosed with breast cancer, you have to advocate for yourself and make sure that you are either seeking that care close to where you live, or you're contacting somebody or us if you're looking for your options, so that you, are making the best decision that you're comfortable with, and hopefully happy with the oncologic and cosmetic outcomes of whatever surgery you're going to end up having.
Thank you, Dr. Khan, for sharing your
Thank
expertise.
you for having me.
Yes, it was fun to have you today. I never really get to see you that often anymore. So, please follow our podcast and our YouTube channels. You can learn more about oncoplastic breast surgery on our website, saveyourbreast.com, and you can learn more about Dr. Khan and her surgery side on drsadiakhan.com, and we will link that below. Thank you.